session. So, as I've mentioned in the publicity slide, this is an initiative that started by ASEAN Association of Neurology to try to uh, improve our education process across the ASEAN countries, and of course, we have trying to open it to other interested learners. So this is the second talk that I'm giving on the same topic. So the first topic was given about a month ago. The first lecture was given a month ago. And in that lecture, I mentioned my basic approach to overcoming this fear of dizzy patients. Okay. And I've sent out that video recording for most of you. But I think from the feedback that I got with regards to the questions and the chats that came through during the talk that I went through later, it was quite clear that some of these concepts, because I was going through a little bit fast, could benefit from a revision. So, like I mentioned earlier on, just like when you watch a serial, before the next episode starts, there's usually a recap of the previous episode. So I'm going to do an extended recap so that you can understand, so that we can deal with some of these things that I kind of like went through very quickly, but reinforce. Essentially, the purpose of this session is to equip practitioners on the ground, especially the junior staff, how to deal with dizzy patients. So therefore, cognizant of this objective, we feel that the committee and I felt that it's better for us to reinforce the fundamental concepts. And then maybe in the last 15, 20 minutes, we can bring out new topics that may be more relevant for the senior staff and for academic interests. Okay, so bear with me, those of you who feel that this is a bit repetitious, but as we know, we learn and we remember by repetition. So for the junior doctors, this may not be a bad thing. So with that, can I just start off by saying that we discussed, and again and again, I will be asking some questions. I don't expect you to answer because this is not the right forum, but I would like you to think about the answer yourself. Because one of the things I've learned over the years, and also when I'm teaching, I found that if you were to try to stimulate the learner to try to activate some of their previous knowledge, subsequent knowledge building is much more foundational. So remember, we said that to overcome the fear of dizzy patients, you have to think about 4 questions. Now, if you can start thinking about, if you remember the 4 questions, what were the 4 questions? Well, basically, the 4 questions were, first, to decide whether the dizziness is a syncopal, lightheadedness, sort of dizzy feeling, which is basically the feeling you get before you faint, and is due to transient hypoxia of the brain, as opposed to vertigo, which we defined last time as an illusion of movement, which means that your sensorium is completely intact, but you get this feeling that you are moving when there's no movement. So that's vertigo. And we also mentioned that vertigo is almost always associated with vomiting, at least nausea. Well, it's unusual for syncopal dizzy patients to feel prominent vomiting. They may get a bit of nausea, but definitely not too much vomiting. So with that, we said that if the person says it is indeed a syncopal dizziness, if it's a syncopal dizziness, how can we mechanistically dissect out this patient's symptoms? And we suggested the last time that syncopal dizziness could be traced to the various anatomical structures that could result in transient hyperperfusion of the brain. For example, it could be a problem with the heart itself, where the blood is being pumped. So if the heart itself is transiently not pumping, for example, heart block, ventricular arrhythmias, then the patient is going to feel transient hyperperfusion of the brain, and that will be translated to transient dizziness. So this behoves us to look at the patient's heart carefully, do a good cardiovascular exam, do a good review of the ECG, including looking at the QTC intervals, looking for delta waves, looking for PR interval abnormalities, and also looking carefully at the chest X-ray for abnormal heart shape. Okay, because not only does rhythm problems give rise to transient hyperperfusion, if there is a problem with the outflow, for example, in young patients who come, in older patients, aortic stenosis, that transient hyperperfusion of the brain could be related to transient blockage of the cardiac output because of an outflow problem. So typically a patient with advanced aortic stenosis will say, oh, doctor, I was climbing 4 flights of steps. At the 4th flight of steps, I was getting a bit breathless and I was getting a bit lightheaded. That's because the cardiac output cannot match the patient's need for that level of that's predicated by the patient's exercise. So look at the heart carefully. Now, if the heart appears normal, then the next thing you have to think about is something is wrong with the blood itself that's being pumped out. And that there are millions of causes, literally. Okay, most of them in general medical sphere. For example, anemia, hyponatremia, hypoglycemia, hypocalcemia, and various other electrolyte or blood-related abnormalities. So remember to look at the blood carefully, clinically, as well as with your laboratory results. Now, if the blood is normal and the pump is normal, perhaps it's the pressure that's transmitted to the brain that is transiently abnormal. Now, this could be due to blood pressure medications. Okay, it could be due to something like sepsis or systemic issues that's causing hypotension. But more commonly in our clinics, it's due to postural hypertension. And postural hypertension is almost always related to the drugs that we give, okay? Or it could be related to some form of autonomic dysfunction. So you notice that I've broken up the causes of syncopal dizziness mechanistically into the various structures: the heart, the pump, the blood that is pumped out of the heart, the pressure that brings it to the heart, and finally, we have to think about what about the blood vessels that's transmitting the blood to the brain. And we mentioned that because we have 4 blood vessels in the neck, and the 4 blood vessels conjugate in the brain as the circle of Willis, it is not common for blood vessel issues to present with syncopal dizziness. More commonly, this tremendous anastomosis that occurs in the circle of Willis allows the brain to compensate for any decrease in blood flow, and only in areas where the flow is not able to cope, the patient presents with transient neurological symptoms. And that is what we refer to as transient ischemic attack, TIA. So it's not common for blood vessel issues in the neck or in the vertebrovascular system to present with syncopal dizziness, with the exception of the posterior circulation. As we know, the brainstem is where your reticular activating system is. So if you have blockage of your vertebrovascular system, obviously there will be a transient ischemic attack related to the brainstem, and that can manifest with various brainstem signs, including transient dizziness. Okay, so this is what we did. And finally, we said that once you've covered all this, remember a common cause of syncopal dizziness, and that is a physiological phenomenon known as vasovagal syncope. And we spent some time last time talking about vasovagal syncope, how to positively diagnose it by the characteristic features, and how to think about rule out features for looking for atypical features. Like, for example, we said syncopal dizziness never occurs, vasovagal syncope never occurs when the patient is lying down, for example. Vasovagal syncope doesn't occur for the first time ever in an elderly person who has never been exposed to similar history in the past. These are red flags for us to investigate a person for other causes of syncopal dizziness and not label them as a benign vasovagal, simple, straightforward faint that anybody can have. Okay, so that's what we said. Okay, then after that we had that's for syncopal dizziness. But we also said that if the person's dizziness is not syncopal in nature, it's an illusion of movement associated with nausea and vomiting, then we have to go on to the other 3 questions. Okay, and we said, what are the 3 questions? Well, first of all, what are the dizziness? Are the symptoms associated with other symptoms referable to the central nervous system? And there are 2 big components of the central nervous system: the brainstem and the cerebral cortex. So if you think about it, you can do a checklist of all the structures that go through the brainstem by going through the cranial nerves. For example, cranial nerve 3, 4, and 6 will cause diplopia-associated vertigo, and that will be pointing towards either the midbrain or the pons as the cause of ischemia or pathology. Then, of course, cranial nerve 5 and cranial nerve 7 causes facial symptoms, numbness and weakness. And then the lower cranial nerves will cause bulbar symptoms, swallowing and speech difficulty. Then, of course, in the cerebral hemispheres, you can have drowsiness as well as weakness of the body, right? One side or the other, or weakness or numbness of the body. So any vertigo associated with any of these neurological deficits, for all intents and purposes, would be labeled as a central pathology, and therefore would require a thorough neurological examination. It is not likely to be a benign peripheral etiology. Okay. Then the next question we asked is are these vertiginous episodes recurrent and bothersome for a period of time, or is the patient coming to you with the first ever episode of dizziness? And we said that if it's the first ever episode of dizziness, there are two possibilities. One, that it is the first presentation of a polyphasic disorder, or it is a monophasic disorder. So therefore, the first presentation doesn't really help us. But if the patient says, doctor, no, don't worry, this is not the first time I'm having these symptoms. This has been coming again and again for the last maybe 2-3 years. Once in a while, I get it for about 2-3 months, and it goes away, and then it comes back again to 3 months. And it's very stereotypic. It is identical in nature with this, in terms of the severity as well as the duration. Then we know that it's a recurrent problem. And we said the recurrent disorders, okay, recurrent disorders would be pathology in the peripheral nervous system, like benign positional paroxysmal vertigo, or pathology in the central nervous system, like posterior circulation, transient ischemic attack, or migraine. Okay, so these are the causes of recurrent spells. But if the patient says, but if the person comes to you with a single episode, then of course, having considered the possibility that this is the first episode of a recurrent illness, then you have to start thinking about a monophasic illness. So what is a monophasic vertiginous disorder? In the central nervous system, it is a stroke, right? Straightforward. In the peripheral nervous system, it is vestibular neuronitis. So essentially, we have only two big disorders to worry about. And then finally, we have to try to delineate from various, either from the patient or from the observers surrounding the patient, how long each of these spells or each spell of dizziness lasts. Is it, and all we need to characterize is not specifically in terms of exact duration, but broadly into whether they are lasting seconds, minutes, or hours and days. Okay. Now we know that episodes that are lasting seconds to minutes are likely to be either TIA or BPPV, while episodes that last hours and days are likely to be things like migraine, things like vestibular neuronitis, or established stroke. Okay, so this is basically what we discussed last week, or rather last month or 2 months ago, and we went in depth in some of these things. But again, in the interest of reinforcing these important points, I'll go through some of the examples that we went through and reinforce some of the learning points. But as I said, this is fundamental for the juniors in the audience. So if, let's say, we take the 4 questions and apply it to a scenario, like, for example, if I'm coming to you, doctor, I'm a 58-year-old gentleman who has vertigo, and it's definitely vertigo because everything around me is spinning, and I'm completely intact with regards to sensorium. But while spinning, I'm feeling very nauseous, in fact, vomited 4 times, including on the way here. So that's clearly vertigo. Then at the same time, I report that I have central nervous system symptoms like dysarthria, dysphagia, and right-sided weakness. This is the first episode ever, and it's lasting many hours. Now, this straight away will make you think about a stroke, and in the modern context, this will require you to activate for acute stroke management. So there are no ifs and buts about this particular scenario, quite clear-cut, and therefore you can proceed on with further evaluation and management of the patient. The second scenario is a bit more tricky and much more common. Okay, patient tells you it's vertigo for the reasons that I have already mentioned. But no matter how hard you go through all the checklist questions that I mentioned earlier, dysarthria, dysphagia, double vision, numbness of the face, numbness of the body, numbness of weakness of the face, weakness of the body, or decrease in sensorium. And the patient says none of these, just isolated vertigo. And he's telling you that it's the first episode ever and is lasting many, many, many hours. Now, many of you at this point will take in information that can help you, but they are not directly relevant to the question at hand. For example, you may say, oh, this is an elderly man, okay, with multiple risk factors, so more likely to be stroke. Well, yes, more likely to be stroke, but this patient can also have vestibular neuronitis. Likewise, if you see a young patient with no vascular risk factors, okay, many of you would say, oh, this is more likely to be peripheral vestibular neuronitis. But you know that young people can get stroke. In fact, young people's strokes are even more devastating, both in terms of for the patient as well for the doctor, because if you miss it, it's very highly likelihood that you will lose your license at the end of it, correct? So therefore, the information that you can take in, peripheral information, I would propose are important for you to understand the patient's background. But still, the key question is not so much whether the patient is young or um, associated risk factors, but only these four questions. And that is why the doctors who are dealing with this day to day have come up with this protocol, okay, which is the HINTS protocol, because we realize that some pieces of information do contribute to the diagnosis, but do not change the paradigm that much. But what really changes the paradigm is vertigo, first episode, lasting many hours, okay, and then you apply the HINTS protocol. This piece of information that you get from the HINTS protocol will help you decide whether it's acute vestibular neuronitis or stroke with a high level of certainty rather than probability like, oh, this is probably stroke, this is probably vestibular, which doesn't help in your management, especially in the modern context when you're thinking about acute stroke management like thrombolysis. So remember, I'm not saying don't take history like smoking, risk factors, age, and all that. Take them on board, but they do not change the needle of the diagnosis. The needle is only moved by the information that we are going to talk about now. What information? Well, let's look at the HINTS protocol. Okay, so HINTS protocol means that in a patient with acute vertigo, first episode lasting many hours, okay, you need to think about number one, okay, is the head impulse positive? Number two, okay, is there nystagmus? Number three, is there test of skew? Okay. Now, if the head impulse is positive and the nystagmus is of peripheral nature and there's no skew deviation, you are fairly certain, no matter whether the patient is old or young, no matter whether the person has got risk factors like stroke, previous stroke, smoking, and things like that, you are quite certain that we are dealing with the vestibular neuronitis. And no matter how severe the patient may be symptomatic, you can manage the patient conservatively as an outpatient without any concern. On the other hand, if the patient comes to you, whether it's young or old, with or without risk factors, head impulse is negative and it's got a central type of nystagmus and it's got skew deviation. Regardless of what the scan shows, this is surprising to many of you. Regardless of what the MRI may show acutely in the first 24, 48 hours, okay, this patient has a central pathology, namely acute posterior circulation stroke, okay, often in the lower part of the brain, and especially in the lateral medullary symptom. So this patient, especially in places where we can't get scanned early, this is a beautiful protocol because it allows you to quickly decide which patients need to be admitted, admit the patient and manage the patient as stroke, okay? And even if you have an MRI, as I mentioned before, the presence of a normal MRI in the presence of a negative head impulse, nystagmus that's central, and a test of skew that is positive, okay, does not rule out posterior circulation stroke, okay? So at this point, just to quickly revise what we did the last time, because these are such important points, let me start asking you and give you a few seconds to think about what is the basis of peripheral nystagmus. Remember, we did the vestibular dance the last time and showed you how to remember why peripheral nystagmus has got some key features, okay? What are the key features? think about it, try to activate what you remembered last time. And then in a few moments, I'm going to reinforce it by going through the points again, so that this is nicely concretized in your head and you'll never forget how to sort out a peripheral mistakes. Okay. So I think many of you are already thinking about some of the mechanisms, but basically we said these are the key features, and rather than memorize it like a laundry list, we said you can work it out using the egg diagram. Okay, what is the egg diagram? Well, you imagine that the eyes look like eggs, and you put the two eggs there, and we want to look one side or the other side. This is the muscles that are moving, and the circuitry in the central nervous system is this. Now, this is reflex movements, and we said that there is one other reflex movement that's very crucial that is actually now acting right in front of you now. For example, you can see I'm quite a restless person moving my head left, right, walking up and down, but nevertheless, I am, without even thinking about it, foveating, keeping my eye with a maximum acuity on you, on the screen. Okay, I don't even have to think about it. And that's because my vestibular system is picking up the stimulus and sending it to the eye and keeping the eye in the point of interest. And that's called the vestibular ocular reflex or the Dawes reflex. And we said to work out how the vestibular ocular reflex works, we just need to remember that there are three semicircular canals in our mastoid bone. One is superior, one is horizontal, and one is posterior, and the other side superior, posterior, horizontal. Okay, and then we have fluid within the semicircular canals, and the fluid is like this bottle, water inside. And when you move the bottle, the fluid will move, and this movement creates eddy currents, and that is picked up by the vestibular nerve and transmitted to the brain as movement. And the brain then moves and moves the eye accordingly, so that the eye fixates on the object. But we went a bit further to make you remember which side the stimulus is coming from. We said that if my head is turning to the left now while looking at you at the screen, my right eye is abducting and my left eye is adducting. That means my right sixth nucleus was active. Now, to activate my right sixth nucleus, where is the stimulus coming from? Well, we said that when we check the head left and right, both sides, the endolymph fluids in the semicircular canals will move, but we alluded to the analogy of the ocean currents. Ocean currents are very strong, but we would not know that they are strong until they hit the beach. At the beach, they create big waves that people use for surfing. So in the same way, when we move my head to the left, okay, this side, the fluid is moving away from the semicircular canal wall, while in this side, it's moving towards the horizontal semicircular canal and hitting against the wall and turning around. So because of that, there will be more eddy currents on this side rather than this side. So this should remind you that when I move my head to the left, okay, it is my left semicircular canal that gets more eddy currents, my right gets less eddy currents. When I move my head to the right, my right gets more eddy currents, the left side gets less eddy currents. Okay, and then that is the efferent part of the vestibular system. The afferent part, we already said, sorry, the afferent part. The efferent part, we already said. When I move my head to the right, my left eye is abducting, my right eye is adducting. When I move my head to the left, my right eye is abducting, my left eye is adducting. So this means that my right sixth nucleus is active. So when I move my head to the left, my left eye is abducting, my right eye is adducting, my left sixth nucleus is active. So now let's put the two together. So I move my head to the left while looking at you. My right sixth nucleus was working, my left, so my right sixth nerve was working, and then through the medial longitudinal fasciculus, my left medial rectus was contracting. Okay, now this is then connected to the which side? Because when I move my head to the left side is the one with the greatest signal. So this dancing with your ears like that, what I call the vestibular dance, will remind you that to connect the eighth nerve to the contralateral sixth nucleus. This is important because when we damage, okay, in acute vestibular neuronitis, we are damaging the vestibular component of the eighth nerve acutely and severely. So what happens? So remember I said, if you move to the left, the side moves more. When I move to the right, the side moves more. But when I'm steady and looking straight ahead, both sides are equally firing at a basal resting rate because they're not dead. They are still resting, but they're still firing at a basal rate. Now, if I come and mischievously damage one side completely, then the other side is firing at the basal rate. But as far as the brain is concerned, This is an imbalance of the right ear to the left ear, and the brain will perceive this as movement to the right. So therefore, even though my head is not moving to the right, my eyes will move as if the head is turning to the right. So what will happen when my head turns to the right? My eyes will move to that side, right? So now my head is not turning, but my eyes are going to move towards the left. And because I'm conscious and I want to look at you now, I'll bring it back. Okay, then you move to the left, and I'll bring it back. Move it back, move to the left, and I'll bring it back. Move to the left, I'll bring it back. So slow phase, fast phase, slow phase, fast phase, slow phase, fast phase. Okay, and that is the basis of peripheral nystagmus. It is the imbalance in the ear that is created by the damage to one ear. The other side firing normally is perceived as increased signal, and the brain will react accordingly, and therefore your eyes move as if the head is turning without the head turning. Okay, so this will remind you that there's no basis for the direction of the nystagmus to change, because no matter whether I look up, look down, look left, look right, the direction of the nystagmus will always be in the same direction, namely away from the damaged ear. Okay, because the basis of the nystagmus has nothing to do with the eye. So it doesn't matter where I move the eye or whether my eye is not moving. Okay, as long as there is an imbalance in the ear, it will be beating, and the beating direction will be away from the direction of the damaged ear. But the key point to remember is that there's no business at all for the nystagmus to change direction. So those of you who are familiar with the Hind's protocol, you realize that this is belabored upon. They would emphasize and reiterate that the nystagmus cannot be changing direction if it is a peripheral nystagmus. While in central nystagmus, it is characterized by a direction changing nystagmus. Okay, so with that, we also went on and said that the reason why peripheral nystagmus is mixed horizontal rotatory is because you have three semicircular canals, right? One is horizontal, one is superior, and one is posterior. Now, if I damage these three here, these three are unopposed. But if you think about it, one superior and posterior are more or less against each other's direction. So they are partially going to cancel each other's out. While the horizontal semicircular canal is the one that is completely unopposed. Therefore, you're not surprised that the nystagmus is predominantly horizontal, but okay, because these guys are trying to cancel each other out, but not completely, there's a hint of torsion. Okay, so peripheral nystagmus is predominantly horizontal with a hint of torsion. Okay, it is not purely horizontal, it is not purely rotatory. Okay, remember, it's predominantly horizontal with a hint of torsion. And finally, we said, just like Romberg's sign of the eye, when you close the eye in Romberg's sign, you tend to lose balance because the pathology is peripheral outside the cerebellum. Likewise, in central nystagmus or in peripheral nystagmus, when you close your eyes, the nystagmus becomes worse because the cerebellum does not have any visual input to know where the eye is, to control the eye and suppress the nystagmus. So therefore, when we close the eyes or remove visual fixation, okay, the patient's nystagmus becomes much more prominent. Okay, so this is what we discussed last time, and I've gone through it in revision. Hopefully, it would have reinforced your learning from the last time. Unidirectional, beating away from the direction of nystagmus, no business to change direction, worse from looking away from the side of the pathology. And finally, okay, Romberg's sign of the eye. And we demonstrated Romberg's sign of the eye by showing this patient whose nystagmus is indeed horizontal rotatory, does not change direction at all, no matter where he looks. And more importantly, when he closes his eyes, the nystagmus becomes much more prominent, confirming that this patient's pathology must be acute vestibular neuronitis. Okay. And then we said that the practical way of closing the patient's eyes and still being able to see, because this is a rare patient where the lids are thin enough for us to perceive the eye movements. The practical way is to use what we call Frenzel glasses. And this is the cheap version of Frenzel glasses, which is self-made. Basically, you get these glasses that are very thick and magnifying that prevents the patient from looking through. So you notice that with the nystagmus, with the Frenzel glasses on, the patient's nystagmus is very prominent. But the moment you take it out, it's just like the Romberg's patient opening their eyes. Suddenly, with visual fixation, the patient is able to suppress the nystagmus tremendously. Nystagmus, no nystagmus. Nystagmus, No nystagmus. Nystagmus? No nystagmus. So this is a beautiful example of Romberg sign that further confirms that this patient's mixed horizontal rotatory beating away from the side of the disease here and is a peripheral nystagmus. And in this case, this lady's acute vertigo is due to vestibular neuronitis. This is another patient with acute vestibular neuronitis. Again, you can see that the nystagmus is quite subtle. Why is it subtle? Because the eyes are open. So she's able to suppress it. But the moment I put on these glasses and prevent a visual fixation, you can see the nystagmus becomes much more prominent, again, helping the clinician at the bedside confirm that this patient doesn't have a stroke, that this is acute vestibular neuronitis. Okay, so this is a summary of that. Okay, now what is the central type of nystagmus then? Okay, now we discussed this at length last time, but again, in the interest of time, and also because I hope to cover some of the other aspects of vertigo, I would like you to refer to the previous recording to go through the details of the mechanism of central nystagmus. But the key point to remember is that it does not obey the rules of peripheral nystagmus, which is peripheral nystagmus is horizontal with a hint of rotatory and is always beating in the same direction. But this lady's nystagmus cannot be peripheral. Why? Because when she looks to the right, it beats to the right. When she looks to the left, it beats to the left. So clearly, this has no basis in the ear. This must be something to do with the cerebellum or the brainstem. So this patient's HIMSS protocol will straight away tell you that this patient needs to be admitted for a stroke management, regardless of what the scan shows. Okay. So this is classic gaze evoked or gaze dependent nystagmus. Nystagmus that beats in the direction of gaze and keeps changing according to the direction. Completely different from peripheral nystagmus and therefore very useful to distinguish the two conditions. Okay. Now, for the more advanced practitioners, okay, there are other forms of central nystagmus that are not common. But the way, and in some of my neuro-ophthalmology lectures, I go through each one of them. Again, in the interest of time, what I would suggest to you is to think about why they cannot fit if any of these morphologies, if any of these morphologies, ask ourselves whether any of these morphologies can fit what is defined as a peripheral nystagmus. If they don't define, then I would assume that this is central. For example, this patient, okay, whose nystagmus at primary position is beating down all the time, symmetrically down all the time, down, 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 down. Now, if you think about it, what pathology in the ear can presumably, what pathology in the ear on both sides can cause such symmetric downbeat nystagmus? Nothing, right? Because how can you just damage one or the other semicircular so beautifully that the patient's nystagmus is always beating down? Cannot. So it must be a central disorder. So it's indeed a highly localizing central disorder. And if you attend my other talks on mechanisms of nystagmus, we will talk about why this happens and how it localizes very accurately to the flocculus, a specific area of the brain, flocculus of the cerebellum, which is at the cervicomedullary junction. Okay. Now, then of course, this is another example of downbeat nystagmus. Clearly, boom, boom, boom. So again, by looking at the nystagmus character itself, you'll know this cannot be. There's no way we can explain it by the way we did for, and that's why I belabored on trying to explain to you the mechanism of peripheral nystagmus. Then you will be able to say, okay, how can a peripheral nystagmus give you downbeat nystagmus? Likewise, how can a peripheral nystagmus give you upbeat nystagmus? Again, this is brainstem pathology. Okay, and likewise, other forms of nystagmus that don't fit the characteristic of peripheral nystagmus, pure torsional, seesaw, pendular, all these are central nystagmus. Okay. Now, each one of them have got a beautiful mechanism behind it. As I said before, in the interest of time and also from a practical point of view, all you need to ask yourself is the nystagmus that I'm seeing in front of me satisfying what I know about the mechanism of peripheral nystagmus? It doesn't, like this man. Okay. Pendular nystagmus, pendular circular nystagmus, okay, associated with palatal movement. Straight away, you know this must be central theta. Okay. So this is what we have talked about so far. And I've kept emphasizing this because I know many of you are neurologists and or general physicians. And you know, this is an important issue because you're dealing with life-threatening posterior circulation stroke versus a benign condition called acute vestibular pneumonitis. Okay. Now, finally, oh yeah, actually, sorry, I summarized it even before talking about the last point. Okay, the last point in the HINTS protocol is the head impulse test. And we said the head impulse test requires a bit of learning. We talked about it the last time. It's basically moving the head fast and trying to see how good your vestibular system is in making sure that the patient is fixating at the point of interest. So for example, now, if you look at my eyes very closely as I'm looking at the screen, you notice that when I move my head very quickly to my left, my eyes are still completely fixated on you. There's not even a hint of loss or gain. On the other hand, if I move my head, maybe I'll take off my glasses so you can see better. So if I move my head to the left right now by thrusting my head like this, again, you notice my eyes are completely fixated on you. If let's say I have left vestibular disease, okay, what do you think will happen when I do the head thrust? This is exactly what will happen. When I move to my right, the normal side, I will still be looking at you. I'll still be looking at you. Okay. But when I move to the abnormal side, you know what will happen? I would do this. For a moment, I will look away because my eyes cannot fixate on you because my left vestibular system is not working. And then after that, I voluntarily, oh, I'm supposed to look at the screen. I bring it back. It's a very fast movement, but still there's a delay. You as the clinician watching from the other side will know, oh, there's a delay. With that delay, you know that left hip thrust is possible. Okay, so it requires a bit of learning in terms of the muscle memory, how to move the head fast enough, but without big amplitude. As I said, this is not like the Exorcist movie where the head turns round and round. You just move the head a little bit, but you have to move very fast. Okay, so for example, here, normal, normal, to the left, abnormal. Okay, if I do it in slow motion, I'll be moving my head like this. My eyes follow the head, and then after that, my eyes will catch up. Okay, my eyes will catch up. Now, what you need to see is the catch up. The catch up saccade. Here, there's no catch up. I'm still looking at you all the time. Okay, so that is the head implant. This is a very specific sign for vestibular dysfunction. So let's look at this lady. Okay, so first I move the head slowly so that she can be comfortable with my head movement. Then after that, I tell her, Madam, look at my nose. 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 I keep emphasizing. Look at my nose. Look at my nose. Poof. She looks away. Why she looks away? Because the left vestibular system wasn't working. She has to voluntarily do a movement subsequently. Watch again, okay? Because this is the best example I have. And I always use the same video because it's the best example. Okay, acute vestibular neuronitis in a young woman. Turn to the right, she's looking at me, she's looking at me, she's looking at me. But then when I turn to the abnormal side, she loses gaze and she catches up. Okay, so it's left vestibular disease. Likewise, this patient, what do you think is the abnormal side? Sorry. So that, so it's a right vestibular disease. And this is the lady we saw earlier on. Remember, she had a right beating nystagmus. The left side is abnormal. So watch what happens when I move the head to the left. Now hers is very subtle. So I purposely put this at the end so that you can get confidence, especially the ones who are advanced in the audience who will have confidence. So watch what happens when I move the left. Sorry, I think I got the side wrong. Remember, her nystagmus was beating towards the to the left. So her pathology was the right ear. So, okay, when I move to the right, the left is normal, right is okay. So just make sure that we didn't get it wrong. Let's go back to her again. Okay. Nystagmus beating to the left. So where's the disease? Right ear. Okay. Right ear. I remember wrongly. So it's right ear. So now when we go to the nystagmus, sorry, hip thrust. To the left, she's still looking at me. To the right, she loses gaze. Left looking at me, right? She loses gaze. So it's just a transient second where she loses gaze and she uses voluntary saccade to pick up. It's very fast. Voluntary saccades catch up very fast. But you will notice the difference between the left and the right. And therefore, even able to pick up a subtle head thrust like this. Okay. So this is basically what we talked about. Okay. So finally, we have the test of skew. Test of skew, I'll keep it very simple. Okay. Again, for the neurologists and the neuro-ophthalmologists or others who are interested in one of my neuro-ophthalmology lectures, I talk about the pathophysiology of skew deviation. But today it suffices to say that in an acute vertigo patient, if you see one eye is up, one eye is down, and the head is tilted slightly to one side, okay? Usually it's to the side of the lower ear, okay? So in this case, the right eye is up, left eye is down, and the head will be tilted towards the left, okay? That is consistent with the ocular tilt reaction of skew deviation. Skew deviation. Okay, once you see skew deviation, this is a central nervous system pathology. Full stop. Okay, in an acute setting, this is a central nervous system pathology. So we are dealing with posterior circulation stroke. So this is the last component of the HINTS protocol. So with that, let's go through a case, okay, and see whether you can. I don't want you all to go straight to the answer. So think through it. So a 55-year-old woman was evaluated in the emergency department for severe vertigo. So we knew that question number one is vertigo because she was vomiting all over and she was saying she's intact sensorium and there's no, and there was an illusion of movements. So she's clearly having vertigo. Okay. Now, you notice that she has a history of hypertension, but it is useful to know that, but it's not going to be extremely diagnostic. What is more diagnostic is to subsequently understand that this is a first episode of vertigo. It's lasting many, many hours. Okay. Okay. But then, unfortunately, for us, she has got no other central nervous system features. So that means we have to think about either acute vestibular neuronitis or posterior circulation stroke. The fact that she's older and hypertension, well, it's useful, but it's not diagnostic. So therefore, what do we do to differentiate between these two accurately, accurate enough for you to manage the patient properly, okay, rather than have two differential diagnoses and not manage the patient, okay, is to apply the HINTS protocol. Okay, so if you apply the HINTS protocol, first thing they did in this particular case, the doctors who managed her, first thing they found was that she had a nystagmus and it was lab beating. Okay, and it didn't change direction on looking to the right. So what is this? This is a peripheral nystagmus. Peripheral. What they should have mentioned is that it's not purely horizontal. It's horizontal, mixed horizontal rotatory. But the important point is that it does not change direction. Okay. Now, then when they put on these Frenzel glasses, in this case, they had Frenzel glasses. As I said before, last week, if you don't have it and if you're doing this kind of thing all the time, it's worthwhile to go to the optometrist and ask them to get the thickest possible magnifying glasses and put into your frame, and that will serve as your Frenzel glasses. Okay. Now, so with the Frenzel glasses, they found that the nystagmus became more obvious. So what is this? Romberg sign of the eye. Okay, because in central disorder, whether you close the eyes or open the eyes, your unsteadiness would be the same. So likewise, in central nystagmus, whether you open the eyes or close the eyes, okay, with or without visual fixation, your nystagmus is going to remain the same. So in this case, the nystagmus got worse, so consistent with peripheral nystagmus. And finally, when they did the head impulse test, it was abnormal. Abnormal in the side that was consistent with that lab beating nystagmus. Okay, right impulse positive. So this diagnosis is acute vestibular neuritis. Okay, and this is a summary statement. Okay, now alternatively, you take an elderly man, okay, with 3 days of dizziness, okay, dizziness, and he describes it as vertigo because he sees things moving around him. Okay, he denies any other central nervous system features. First time ever, lasting many, many hours. So again, we have no choice but to apply the HINTS protocol. Okay, to differentiate a posterior circulation stroke from a peripheral vestibular neuronitis. So here, interestingly, he has got no nystagmus to help us. Okay. Now, uncovered test demonstrated normal. There was no skew at all. no skew deviation. And the head impulse test was absent. So what are you going to do? So in other words, everything is absent in this patient. No central nervous system feature. Okay, in terms of symptoms, at least, yeah. Then no nystagmus to help us. Okay, cover test. You don't have to do a cover test, but if you just sit in front of the patient and watch him closely, one eye is not higher than the other. Both eyes are the same. Head is not tilted to one side. There's no skew deviation. Okay, and the head, but the important thing is head impulse was negative. When you're sure it's negative. So how? So in other words, the absence of finding is not as useful as the presence of finding. So if you find the head impulse is positive, okay, you know for sure it's a peripheral disorder. The absence does not, in this particular case, the absence, okay, will tell you that this, because in a person who comes to you, okay, I'll repeat that again in case I confuse you all. But basically what I'm trying to say is that if a person has got vestibular neuronitis presenting with acute vertigo, okay, now why is the head impulse negative? It could be because we are not experienced in doing it. Fair enough. So if you're not experienced in doing it, then you have to ask for somebody else more senior to come and do it, or go for ancillary investigations like MRI and things like that. But if you have been doing it all the time and you're quite confident, like in this case, okay, these are the original authors of the Hinge protocol. They say for sure no hit in passport. Then you have to ask yourself, why is the acute vestibular patient, why is the patient negative? Can we ignore this piece of information? So absence of evidence here, okay, absence of evidence, and this is what I refer to as the dog that did not bark in the night. So, for example, a person who coughs and comes to you with a normal X-ray is as useful as a person who comes to you with cough and upper lobe shadowing, right? Because both of them have got certain connotation. So, the same way, the fact that this patient has got severe acute vertigo lasting many hours, but has got no impulse test, is as useful as somebody else who comes to you with acute vertigo and has got a impulse positive. So the absence will tell you that this is very suspicious for a central nervous system disorder. So by the strict criteria of the Hinge protocol, and the Hinge protocol is very strict, this doesn't satisfy peripheral pathology. This patient needs to be evaluated by admission, observation, and if possible, imaging. And in this case, even a simple CT scan showed a bleed in the cerebellum. Okay, cerebellum. Now, but what is missing? What information is missing in this particular paradigm? What is missing, and it's actually implicit but not explicit, is that the neurological exam must be complete. So you cannot just apply the hints on its own. Okay, you must not do the hints on its own. It's only after you have done. Remember, second question, CNS features. First question is vertigo, no vertigo. Second question is what? Is there any CNS features? Both history and exam. So you need to do a full neurological exam of all the cranial nerves, limb exam for neurological deficit, pronated rib, finger nose dysmetria, visual fields, everything is normal. Then you apply the HINTS protocol. Okay. So this is the reason why, although the HINTS protocol is well published, personally, when I apply it and when I teach my residents, I always try to add two other acronyms to it, which is here the VS HINTS, very special HINTS. Okay. Here the very special HINTS. Why do I say that? It's to remind you the VS is supposed to tell you it's very special. Very special because on its own it's useless, but it must be applied to the full neurological exam. And the VS is supposed to remind me of two exams that I often forget to do in a full neurological exam. One is to check the pupil size in darkness to make sure that I don't miss Horner syndrome. As you know, for Asian patients, it is failure to dilate, so it's easy to miss Horner syndrome in bright circumstances or when we use a torch and shine the torch directly into the eye. So V is supposed to remind me to look for, VS is supposed to remind me to look for Horner syndrome, and the V is supposed to remind me that I cannot forget the visual field exam as part of my full neurological exam. Okay, so very special hints. But why the here? Here has come in because people have studied this very carefully and realized that in acute vestibular neuronitis, the presence of a hearing loss does not make the diagnosis acute labyrinthitis as it's been propagated in some books and propagated by some doctors. Okay, in our opinion, acute labyrinthitis, okay, is in this particular context, viral labyrinthitis is a very dangerous diagnosis because most times when you lose hearing acutely in 1 year, at the same time as developing vertigo, it is not labyrinthitis. It is actually posterior circulation stroke because the hearing apparatus, the cochlea, okay, has got the same blood supply as the semicircular canal. So when the person develops acute vertigo at the same time as acute sensory neural hearing loss, it is not labyrinthitis, it is acute posterior circulation. I'm not talking about chronic dizziness. I'm not talking about chronic hearing loss. I'm talking about acute hearing loss that occurs together with vestibular symptoms. So this has been studied carefully by the original doctors, Dr. Kata and Tucker, and Newman Tucker, who wrote up the HIMSS protocol in the first place, and found that one of the reasons why people use the HIMSS protocol wrongly is number one, like I alluded to earlier, not paying attention to the absence of interest. Number two, okay, not doing a full neurological exam. Number three, not taking into account hearing. And that's why the hear part is coming to the HIMSS protocol now. And lastly, the last point that I want to emphasize, okay, this is key, is that remember, we only apply the HIMSS protocol after we have said that this is an acute vertigo. Okay, there's no CNS features. Because if there's CNS features, you don't even have to apply HIMSS protocol. Number three, this is the first episode of vertigo in a patient with no recurrent spells in the past, okay, and lasting many, many hours. So if you don't apply the HIMSS protocol properly, okay, you're going to get into misdiagnosis. Like, for example, this patient, okay, this patient comes to you with vertigo. He's got no central peripheral nervous system features, but he says, doctor, I've got recurrent spells for the last 3 years. Each spell is very, very short. What is the most likely diagnosis for him? Because it's been going on for many, many years and he hasn't gone on to develop stroke, the most likely diagnosis is BPPV. Okay, in an acute setting, if it's coming on only for the last 2-3 days, you have to consider a posterior circulation TIA. But this cannot be acute vestibular neuronitis or acute posterior circulation stroke if it's been going on for many, many hours, many months and years, right? So therefore, if you go and apply the HIMSS protocol on the patient, of course, the HIMSS protocol will suggest that this is central nervous system pathology. Correct? If you take a patient with BPPV and you do the head impulse will be negative. There will be nystagmus that may be present only during posture, but during normal examination, there will be no nystagmus. And of course, there will be no skew. But the absence of head impulse will make you think that this is central nervous system patient, and all your BPPV patients will be admitted to the hospital as acute stroke. So there will be a problem. So why? Not because the HIMSS is wrong, not because your technique is wrong, but you have applied in the wrong scenario. The scenario is not for an acute vertigo that in the context of somebody who's got recurrent vertigo for many, many months and years. This is obviously some other pathology. And in the case of peripheral nervous system, it's BPPV, and that requires something else. Okay. And in an acute setting, meaning if the person says, doctor, I've been only having these spells in the last 2-3 days, then of course you have to consider whether this is a vertebral artery or basilar artery disease presenting with a TIA. Okay. But definitely not a posterior circulation stroke or acute vestibular neuronitis because of its nature of it not being continuous and ongoing. Okay. So remember the last point, that the reason why HIMSS is wrongly applied is because people do not appreciate that it's only meant for an acute vestibular neuronitis or acute stroke sort of setting, so-called acute vestibular syndrome. In a person who presents acute vertigo lasting many, many hours and with no previous spell, okay, and that's when you apply. Okay. Okay. So now what about these patients who have recurrent spells? Well, the commonest cause of this recurrent spells will be BPPV. And again, unfortunately, in the context of a Zoom teaching, I can't show you these techniques, but they are supremely important because BPPV is super important and super diagnostic. The therapeutic, the diagnostic maneuver. The diagnostic maneuvers are bedside clinical exams that give you just like hitting pulse and evaluation of your nystagmus, gives you a high degree of certainty that you are dealing with PPV. So you must master it. How do you master it? You can learn it from your teacher, or you can come to one of our physical workshops, or you can look up the multiple videos that I have referenced in the notes. There are many videos available on the YouTube. Okay, I have selected those that are correct because there will be fake news, of course. So learn how to do the Dix-Hallpike maneuver because it is an extremely useful maneuver. For example, in this case, this doctor is doing the Dix-Hallpike maneuver and he's put on the frontal glasses so that you can see it. You don't need frontal glasses for BPPV, okay? But here, just for the sake of demonstration, he's put it, and you got this beautiful eyebrow beating nystagmus. Remember, it must be beating towards the eyebrow. If it beats elsewhere, the criteria for BPPV is not satisfied. So remember, when you put the head down, number one, there will be latency, there will be a period of quiescence. Then the nystagmus will come on. The nystagmus will be beating towards the eyebrow, okay, of the patient. Now, why do I say towards the eyebrow? Because it's the easiest way to describe it, because you put the patient's head down. So if you say downbeat, upbeat, it's likely for the listener or the learner to misunderstand my instruction. So what I'm trying to say is that, remember, it must be an eyebrow beating nystagmus. And it goes on for a period of time. And then after a while, it dies off because of habituation or fatigue, okay? So this is the key features of benign positional paroxysmal vertigo. Now, once you've mastered it, then you realize that there are other forms of BPPV that affects your other canals. Remember, superior cervical canal is here, posterior is here, horizontal here. Okay, so every time there is debris in your semicircular canal, the debris is going to fall into your posterior canal. So therefore, posterior canal is very common. Okay? Now, if the debris don't fall into the posterior canal, they can accidentally slip into the horizontal canal. So therefore, horizontal canal BPPV exists in about 20 to 30% of patients. And that is something that you need to master if you are somebody who's seeing busy patients very frequently, or if you are in the emergency department. Because horizontal canal BPPV is terribly underdiagnosed. Okay, how to do that? You do a maneuver, which is even simpler. This is called a supine head roll test. You turn the head. Remember, this nystagmus is not present at primary position. In BPPV, you shouldn't get nystagmus in primary position. Remember, let's revise that. It's a person with vertigo, okay? No central or peripheral nervous system features. Recurrent spells lasting few minutes. Then you consider BPPV. Now, if the person is having ongoing nystagmus in front of you, cannot be BPPV. Don't go and do the Dix-Hallpike test or anything like that. Something is wrong with your evaluation. Go back. Okay, you may be either dealing with a stroke, that means you misunderstood this is a recurrent spell, or it's a short spell and thought that this was a So in the earlier algorithm, like what we said, is the earlier scenario of acute vestibular syndrome if the patient has ongoing nystagmus. So don't do BPPV test in a person with ongoing nystagmus, because ongoing nystagmus means either acute vestibular neuronitis or posterior circulation stroke, which is the earlier scenario. The HINTS protocol is applied. But in a person with no nystagmus at quiescence, then you position the patient and the nystagmus comes out. That's why it's called positional nystagmus, positional vertigo. Okay. So in this case, no nystagmus is a primary position, but when I supine roll him, supine, S-U-P-I-N-E, R-O-L-L, okay, supine roll him, then you get this nystagmus. Okay. This is classic of horizontal canal BPPV. And then there is a subsequent need for you to triage this into beating towards the ground nystagmus or away from the ground of nystagmus. And then from there, you can decide which ear is affected. Okay, all these rules are easier read than explained, especially in a video setting, especially in a Zoom setting. So I've put all this in the notes for you to reference. Okay, so look out for this nystagmus that occurs only when you turn the patient's head in a supine position and it's beating, okay, in one direction, either towards the gravity or away from gravity. Again, like all peripheral nystagmus, it doesn't change direction. So always beating in relation to gravity, it's always beating either towards gravity or away from gravity. So remember that. Okay, from there, you can then decide which ear is affected. And from there, you can then decide on the therapeutic maneuver, which is known as the Guffoni maneuver. Okay, now Guffoni maneuver is a troublesome and difficult to master and poor efficacy sort of maneuver. So please learn how to do it. But more importantly is to learn the apply maneuver. Because apply maneuver applies for the posterior canal BPP, which is much more common, okay, and much more satisfactory, very easy to do, and extremely, extremely effective. Okay, so there's no reason why you don't do it because it's so easy to do. Okay, so this is apply maneuver. Put the head down.
Patient's head is then brought down. One looks for the nystagmus.
So this is the right.
This could usually be done with Francis
posterior canal BPV. So turn the head all the way to the other side.
Toward the other side.
And then when you can't turn anymore, turn the body because you can't turn the head anymore.
Nystagmus. It should be in the same direction as the initial nystagmus with the right leg bend. And then the patient.
That's how you remember it. Turn the head as much as you can. Cannot turn anymore, turn the body. After that, get the patient to sit up. That's it. So turning the patient's head to as much as possible to the other side until you can't turn anymore, then turn the body and then get the patient up. So easy to even remember, all right? So easy to do, so you must do it because this is 1,000 times better than any of the nonsense medications we give like metoclopramide, stuff like that, which harms the patient. Okay, but the maneuver on the other hand and fixes the problem immediately on the spot. Okay, so please master it, and these are the various videos. I've given a few examples of each one of the maneuvers so that you can cross-check and learn it from each other. Okay, now finally, we have one more scenario to quickly we covered last time, and I'm just going to emphasize again. Somebody who's got recurrent spells, but not lasting seconds, but lasting many hours. For this patient, of course, I would still do the BPPA test because sometimes patients can confuse us and tell us that it's lasting many hours, but actually it was very transient. They may exaggerate it because of the feeling of discomfort they have. So do the dizziness test and make sure that you're not missing it. Okay. Then after that, you consider the most likely diagnosis, which is migraine. Okay. So migraine is the most common cause, especially in young patients. Recurrent vertigo that's lasting many hours, that's been going on for many years. Okay, sometimes it gets worse with position, okay, and they often misdiagnosed as BPPV, okay, but most of them don't have the dizziness test, will not have the supine head roll test, okay, but they may say that they are, which is like any migraine patients, they don't like movements. Migraine patients, as you know, they like to sit in a quiet, dark room. Put a migraine patient in the back of the car and make the person turn up and down, or put him on a boat and turn him up and down. Of course, it's going to be more nauseous and motion sickness. You all know migraine patients are tremendously motion sick prone. Okay, so therefore, movements, okay, will make migraine worse. So positional symptoms are actually quite characteristic of migraine. So be careful. But the key point is long or short. If it's long, it's most likely migraine. But nevertheless, you would do the dizziness and supine head roll test to rule out BPPV because even young patients occasionally can get it. Of course, the other thing is to help you is that BPPV is extremely uncommon in young people, much more common beyond middle age. Okay? Why should young people get BPPV? Usually it's secondary BPPV. What is secondary BPPV? Again, for the advanced practitioners, you need to know it. It is due to some damage in your posterior, in your semicircular canal. Okay, your semicircular canal is either damaged by head injury. For example, the patient is involved in a major road traffic accident. Okay, the contusion in the semicircular canals will lead to bleeding and debris, falling. Where will they fall? Well, they will fall into the posterior canal. Okay, so this debris in the posterior canal will cause a secondary BPPV. So these patients with head injury, they're coming out of the neurosurgery ward, they'll complain of recurrent dizziness and they'll be often labeled as hypoxemia until you do the head impulse, sorry, not a head impulse, dizziness test or supine head roll test, and then you can diagnose it. Okay, so likewise, somebody who has got severe acute vestibular neuronitis, after they have recovered from acute vestibular neuronitis, there's damage to the vestibular system, right? There's damage to the semicircular canal. So whenever there's damage, there's going to be debris. Where will the debris fall? Again, to the dependent posterior semicircular canal. So again, remember that in young patients, still BPP is possible, but almost always is due to a secondary cause. It's due to an underlying pathology. But in older patients, it is just part of aging. Just like kidney stones and stones are more common in older patients, stones inside, okay, otoliths inside your semicircular canal are much more common in older patients, okay? So in young patients, remember but migraine, how you manage? Exactly, you manage like a migraine patient, okay? Just like migraine patients, you avoid analgesics here, you avoid like poison, you must avoid vestibular sedatives. Otherwise, you're going to harm these patients, okay? Use proper migraine medications, migraine prophylaxis. Don't use vestibular sedatives. You're going to make them Parkinsonian in the end, okay? And secondly, you're going to screw up their vestibular system, okay? We'll talk about that more in a month. Then finally, I said, what if you see patients like him who have constant feeling of disequilibrium? Okay. Now, constant feeling of disequilibrium that's present all the time. So then that's when you have to think about functional disorders. Now, functional disorders is not always, as you know, functional disorders are not the same as malingering. It's not the same as hysterical. It is a reason, it's some sort of a reset in your system. You become hypersensitive to movements. For example, now, if you see me, if I were to like do this, shake my camera in front of you, many of you will know that it is the screen that is not moving. The screen that is moving is not you that is moving. But sensitive, okay, to movements as a person, okay, for whatever reason, functional reasons. You know, sometimes maybe related to anxiety also. Then this movement will be perceived as your own movement, you know, and you get very uncomfortable. Okay, the same reason why you feel uncomfortable if you're standing on top of the Eiffel Tower and looking down, even though you know you're not going to fall, you feel like you're going to fall because you are on a on a at a height, right? But if you were to come down the Eiffel Tower and stand at the foot of the Eiffel Tower with the same pair of shoes, same legs, same cerebellum, same vestibular system, same person, okay, you will not feel unsteady. Why? What's the difference? You ask yourself, right? The reason, just because you're standing at the edge of the cliff doesn't mean you will fall off, right? But in fact, if you had stood at the edge of the building, at the edge of the Eiffel Tower, and you got somebody else to blindfold you, you would probably feel comfortable standing there for many minutes without any falls. But the moment somebody takes off your blindfold, and you know that you are at the edge of the Eiffel Tower, you will straight away feel unsteady. You feel like you're going to fall, and you'll take a step back. So this is the mind's tremendous influence on the vestibular system. So if you don't appreciate that, then you cannot be a good doctor in managing vestibular disease, because this is a problem in both patients with vestibular disease as a secondary phenomenon, anxiety and nervousness about falling, or it can be a primary problem in functional patients due to anxiety or some other hypersensitive sort of reaction. As you know, migraineurs are already hypersensitive to movements, to light, to sound, to not smell. So they can be also very sensitive to movements. So they are likely to come and say, doctor, I'm dizzy, I'm dizzy, I'm dizzy, and things are moving around. So this is when we sometimes use words like perceptual dizziness or psychophysical vertigo, which means that the vertigo is not because things are not working well, but your system is so sensitive that it's moving normal movements, you know, like the fan moving, the trees moving, or a little bit of buzz movement of the things around you. You perceive this movement as abnormal and start correcting for it. So it's a perceptual problem. So to do that, what do you need to do to treat that? How do you do? If there's an underlying migraine, of course, you treat the migraine. But more importantly is to desensitize it by getting the patient reconfigured to understand what is normal reaction. Okay. So just like putting dark glasses when a person has photophobia, you need to reduce the patient's sensitivity. How do you reduce the patient's sensitivity? Not by giving vestibular sedatives, which will just screw up your vestibular system, make it even weaker. What you need to do is to get the patient adjusted to the movement. How do you do that? That's what vestibular therapy is all about. And for many places where vestibular therapy is not available, then basic balance exercises that a lot of Asian philosophy advocate, like yoga, tai chi, qigong, are perfect. In fact, they are superior, in my opinion, than vestibular therapy in managing these patients, because basically they concentrate on making the patient move very slowly, focus on themselves, to calm themselves down, control the breathing, get in touch with the environment and understand what is moving, not moving. And then because you're moving slowly, you have to take control of each part of your body, become aware, not too aware, not less aware, but aware of all parts of your body and control it. And that is what Qigong philosophy and Tai Chi philosophy is. So it's actually very useful for vestibular patients. So please advocate that. So that's what you should do. Shouldn't give vestibular sedatives. And finally, before you label anybody, okay, as psychosomatic, after you've done a full neurological exam, you find nothing wrong and you want to label it as psychosomatic. Remember that bilateral vestibular disease is difficult to do, difficult to detect, because bilateral vestibular disease means both sides vestibular system is gone, right? So all the signs that you'll find, nystagmus, PPD signs, sulfite test, everything will be negative. Everything will be normal. So you may think that this is psychosomatic. So before you do that, remember to do two things. One is Romberg sign, because Romberg sign will tell you that the patient's imbalance could be in the vestibular system if the peripheral nervous system is normal. Of course, if the Romberg is positive and the peripheral nervous system is abnormal, you don't know. But if the peripheral nervous system is normal and the Romberg is positive, then you have to suspect bilateral vestibulopathy. Another thing that you should do is the head thrust, but in this case, the head thrust will be positive on both sides. Okay, so like this patient. See, both sides, his eyes follow the head. In fact, it's so bad that he doesn't even remember to bring his head eyes back to look at it. So bilateral vestibulopathy. Okay, so remember, bilateral vestibulopathy can look very psychosomatic. So what is the commonest cause of bilateral vestibulopathy? In terms of the commonest cause, it's us. Okay, us giving aminoglycosides, especially in the internal medicine department, where we often use amikacin, right? For many of our UTIs, we use amikacin for peritoneal dialysis patients who develop peritonitis. Now, the problem with all these aminoglycosides is that your interpretation of your aminoglycoside level is extremely useful to protect the kidney, but it doesn't protect the vestibular system. Okay, so be aware that these patients, after a period of time when they are treated for UTI and all that, these elderly patients get up and then they can't walk, and everyone labels them as functional decline or or something like that. But actually, it's due to bilateral vestibular disease. So if you do the Romberg sign, they will be positive. Head thrust sign will be positive on both sides. And for the advanced practitioner in the audience, another quick way of assessing bilateral vestibulopathy is to do what we call a dynamic visual acuity. So basically, you get a chart, a reading chart that the patient is able to read anything, words written on a piece of paper or your handphone, and then get the patient to read it, and if you can read it well, no problem. Then after that, you move the head. Okay, the patient should be able to read the same words, okay, with the head moving. Okay, but if the person starts saying, "Oh, I can't read anything," that means he's not able to keep his eyes on his vestibular system is not working. So all of you can experiment now. You take a piece of paper in front of you now and read it. Okay, you should be able to read it whether heads are moving, even when the head is moving left and right. But when you move the object left and right, you can't read it because your vestibular system can't work. Now, for the patients with bilateral vestibulopathy, reading will be like moving the object. They can't read anything. So that is another easy way that we often do in the hospital to check the patient vestibular toxicity. Okay. And of course, the other common reasons why bilateral vestibular system is abnormal is patients are given too much vestibular sedatives. Okay. In fact, so far in my last 1 hour discussion, I've been emphasizing time and again. Whatever I've been emphasizing, don't use vestibular sedatives. Why? Because they have very little use. Okay, they have only small area of use in the acute, very symptomatic period of any vertiginous syndrome. You can give it to them at maximum 1 or 2 days. That's it. After that, continuing vestibular sedatives. Okay, especially in patients who don't even have vestibular disease. Sometimes they have syncopal dizziness from cardiac disease or anxiety, and they're given stamityl, metoclopramide for years on end. So what's going to happen? Firstly, they're going to develop Parkinson's disease. Secondly, the vestibular system is going to go, it's going to get weaker. And when it's weaker, what's going to happen? Of course, the patients get more symptomatic. So you end up giving more vestibular sedative and you're making it weaker. It's the analogy I often use is somebody develops cataract. Instead of fixing the cataract, you make the patient more blind. You screw up the optic nerve somehow by giving maybe ethambutol or some other optic nerve toxicity. You don't do that, right? So why are you doing it to the ear? Don't. So please don't give vestibular sedatives unless the patient is right in front of you, vomiting in front of you and messing up your clinic. Okay, then give them a little bit of vestibular sedative and only for maybe a day. That's enough. After that, the brain, the cerebellum will know what to do. Anybody who requires long-term vestibular sedatives is trouble. Okay, trouble for you and trouble for the patient. Okay. Now I've listed out the other causes of bilateral vestibulopathy, important from the general medical point of view. As you know, meningitis can cause deafness, but in addition to deafness, it often affects bilateral vestibular system. And syphilis is another important cause of bilateral asymmetric hearing loss, as well as vestibular dysfunction. Of course, there are some autoimmune causes. Okay, they usually have other manifestations. They don't just present the ear alone. So not to worry, but important to remember that these disorders are associated with vestibular disease. And then one other condition that is relatively common but not appreciated because of the prominent cerebellar pathology. Often people miss that in Wernicke's, in addition to the cerebellar pathology, they have bilateral vestibular pathology. So one good way of diagnosing Wernicke syndrome in an acute emergency setting is to do the head thrust. If the patient allows you to do head thrust, in spite of his confusion and all the other symptoms Wernicke's patients have, then you can make a bedside diagnosis to justify large amounts of parenteral timing for such patients. Okay, and of course there are some interesting genetic diseases that I talked about before in some of my lectures. Okay, the common one that we see is spinocerebellar degeneration type 3. Very interestingly, these patients can be diagnosed at the bedside as possible as SCA3 because in addition to the signs of SCA, they also have bilateral vestibular disease as evidenced by bilateral head thrust. And of course, recently we've been looking out for this condition called canvas syndrome, which is cerebellar ataxia, neuronopathy, and vestibular areflexia. So it's another genetic condition, and that's exactly what this gentleman has. So he has evidence of both neuronopathy, peripheral nervous system pathology, cerebellar disease, as well as bilateral vestibular disease, and that's why he has got head thrust sign. Okay, and very interestingly, he has another very interesting sign called the VVOR test. So this is the VVOR test. And just to make sure that you attend my next lecture, if you want to know what a VVOR test is, we'll talk about it at the next lecture. Okay, so with that, I'm going to summarize by saying that I'll summarize our key learning points. Remember, always to get it right, like I said, like I always say to my residents, just like a pilot, you want to get it right 100% of the time, not 99% of the time. So pilots use checklists because they want 100% safety. So the same reason, you want to get it 100% right, always let's not make instinctive diagnosis. Try to go through a checklist of 4 questions. Okay, and likewise, if the checklist tells you that it's an acute vestibular syndrome that's going on for many, many hours for the first time ever, okay, then you have to use another checklist called the HINTS checklist. Okay, and we talked about the key components of the HINTS checklist, which is the head impulse and the type of nystagmus. And we taught you some way of remembering how a peripheral nystagmus is like, so that you will never forget what peripheral nystagmus is. And by contrast, then diagnose central nystagmus. Okay, we emphasize how commonly HINTS is wrongly applied. Okay, and when HINTS is applied for the patients with recurrent vertigo, patients with no vertigo, okay, patients who have not been examined, the nervous system is not completely examined. You know, the patient already has central nervous system, and then you go and apply HINTS. That's when the HINTS fails you. Okay, it's not HINTS fails you, we have failed HINTS. Okay, then I emphasize the importance of picking up BPPV because it's a common diagnosis and very useful in terms of treating the patient and the usefulness of learning the practical aspects of the Dix-Hall pipe test and the therapeutic applications. Okay, then I emphasize the importance of remembering migraine as an important cause of dizziness in young patients. Now, I never mentioned Meniere's again, simply because in relation to all the conditions we talked about, Meniere's is super rare. Often migraine is wrongly labeled as Meniere's. The reason why you have to think about Meniere's is when patients develop progressive hearing loss after multiple episodes of vertiginous spasms. Okay, so that is Meniere's syndrome. Okay, and that requires you to then send the patient for evaluation to see whether the pressures within the inner ear are high. Okay, the key point is recurrent vertigo associated with progressive hearing loss. Okay. Now, in the absence of progressive hearing loss, you are likely to misdiagnose migraine as dizziness. Okay. Remember, anxiety is one of the most important causes of dizziness, either primarily the cause of dizziness or as a secondary manifestation of the patient's vertigo. Okay. So if you don't manage the anxiety well, either by counseling, pharmacologically, then you are not going to manage the patient fully. The patient is never going to be happy. And finally, if I can say, I'm not sure how much more I can emphasize, but if there's one thing that you must remember is to avoid vestibular sedative as much as you can. With that, thank you very much. And I'll wait another 5 minutes for any questions. If there are no questions, we'll send out the recording in the usual way that we did the last. Okay, thank you very much for your attendance, and I'll wait for questions. This QR code is for the notes, huh? Okay, guys. Goodbye. See you at some point. Thank you.